Welcome everyone to our opioid risk assessment series here at Mountain Pacific Quality Health. My name is Stevie Tsai. I'm a pharmacist with Mountain Pacific. I also am our clinical analyst. Here I work on translating data into usable information for healthcare consumers. And I am joined today by Kevin from Sync Health. He is responsible for pharmacy systems at Sync Health, including the coordination of operations and enhancements of their PDMP, and serves as the primary liaison between Sync Health professional associations, member organizations, and stakeholders in relation to PDMP data collection, reporting, training, and public health. Prior to joining Sync Health, Kevin served as the pharmacy informatics coordinator for the Nebraska Methodist Health System for more than 19 years. He graduated from the University of Nebraska Medical Center College of Pharmacy in 1986 and is very experienced in clinical pharmacy, geriatrics, behavioral health, as well as hospital and community pharmacy. Kevin has served on the Nebraska Board of Pharmacy for over 10 years and has served as a member of the Nebraska Board of Health for over 6 years. He's active in numerous organizations, speaks locally at state levels and nationally for activities surrounding Sync Health and the PDMP. And we are so grateful to have you join us today, Kevin, to share some of your expertise.
Thank you.
Yes. Just some housekeeping today. If you do have questions, comments, anything like that, responses to some polling questions, please feel free to pop those into either the Q&A or chat is a little bit easier. Make sure that you have that on host and to everyone for those chats so that we can have good conversations. We're hopeful that this could be an interactive session and we will have time for question and answer at the end of today's session. So with that, we'll go ahead and get started. If we can go to the next slide, please. We do have some series learning objectives for you. I'm not going to read them out loud to you, but you can see them there on the screen. Broadly, we just want to make sure that we have some good discussions about how we do opioid risk assessments and how universal screening and the different electronic tools we have available to us can be implemented to reduce patient risk and reduce harms for patients that are using opioids or may have pain management needs. Next slide. So to kick us off, we're going to have a discussion about how COVID-19 has impacted opioid risk and the things that we're seeing nationally and locally in terms of how the landscape is changing with opioids. We will be using Wyoming as our primary example today for local data, but please know that Mountain Pacific serves Alaska, Montana, Wyoming, Hawaii, and the Pacific Territories. And then Kevin is very knowledgeable about Nebraska. And so if you have questions about those specific areas, we're hopeful to help you there and can also connect you with local resources if you happen to fall outside of those areas. Next slide. So this is a very common graphic that we're all very familiar with at this point. It speaks to the way that opioid overutilization has evolved and how overdose deaths have been impacted with changes in our trends in terms of prescribing, availability of heroin, and then the introduction of synthetic opioids, including fentanyl, into our illicit markets. So all of those things have really contributed to dramatically increasing overdose deaths from opioids. Most notably since 2013, when we had that third rise that is contributed to the synthetic opioids. We are still seeing those things trend up. If we can go to the next slide, please. So when we start talking about COVID-19 and the way that society has changed with the introduction of lockdowns and just really dramatic public health concerns sweeping through the nation, we know that that impacted substance use disorder in general, including opioid use disorder. So this is a map of % change in overdose deaths from opioids from October 19 to October 2020. And you see a 30% increase in those overdose deaths during that time period. There are a lot of factors that went into that, but overall, we know that pretty much across the board, we saw an increase in substance use disorders and mental health issues nationwide. And unfortunately, that did contribute to losing more people to opioid overuse and overdoses for a multitude of reasons. Next slide, please. So even as we move further into the pandemic and things sort of calmed down, we started to be able to utilize healthcare more. People had better access to mental health services and to their mental health support networks. We continued to see an increase in the number of overdose deaths. So Wyoming is an outlier, along with a couple other small locations where we have a predicted or a reported decrease in overdose deaths. So in 2020, we had 99 overdose deaths. And in this time period, October 2020 to October 2021, we had 97, so a reduction of about 2%. But it's important to know when you see Wyoming show up as blue on here that we are underreported because of incomplete data, because a lot of this is pulled from vital statistics and other reports where there is a data lag. And again, COVID impacted things. It increased that data lag, pulled people off of those projects. And so even though it looks like perhaps we made improvement after things settled down and we moved further into the pandemic, likely that is not true. We likely have continued to see, at a minimum, things remain stable. Probably we continue to see that trend up where substance use disorders negatively impacted the outcomes for our patient population. Next slide. So this is looking again at that overdose death rate, and this is nationwide. You can see the predicted value versus the reported value. So sort of what we thought was happening with the data and then what was concluded to be happening as more things were finalized and those data sets were completed. And you can see that, again, we've just really continued to trend up. And there's this marked timeline where as the pandemic kicked in, you can see that slope of that line accelerate. So nationwide, we were seeing more overdose deaths. Next slide, please. And again, this is Wyoming. We have smaller numbers here. And so you can see that contributes to a lot of variability. But again, we're still sort of trending upwards, which makes sense given how we follow national trends and those sorts of things. I just wanted to point out that all of this information is available at a state level for everyone. This is on the CDC website. And it can really give you a good snapshot of what is happening locally in your community so that you can get a feel for how this continues to impact people. We have so much going on in the healthcare world that I feel like opioids took a little bit of a backseat, much needed during the pandemic as we got our arms around how COVID-19 would change our healthcare delivery system. But we are very much seeing the continued impacts of that, not only in overdose deaths, but overdose deaths just give us a little snapshot of what's happening in the background. For these deaths, we also know there are people who are having overdoses that they survive. Thankfully, overdose is not always fatal. And so it just indicates continued need to help prevent opioid use disorder from developing across the board. And we're hopeful that as we talk about opioid risk assessment, we can begin to have those discussions. Next slide, please. So when we talk specifically about sort of our geriatric or our Medicare population, this is for the Mountain Pacific territories where we cover, again, Alaska, Hawaii, Wyoming, Montana, and the Pacific territories. We're also able to look at adverse events in general. This is a claims-based analysis. So the red line there is how we're trending in that area, and the blue line is the rate of adverse events. This includes people who are presenting at the hospital or the emergency department with things like respiratory suppression from opioid overdose, falls related to opioids, confusion related to opioid use. And we're seeing all of these things continue to creep up overall or remain stagnant. Depending on what community you live in, we've seen some really dramatic increases. And then overall, like I said, for our area, it's very stable. And this is an indicator that we aren't having good luck reducing the risk for patients, especially those over the age of 65 that are really vulnerable for those bad outcomes. If you have a fall related to opioids in your 70s, chances are very high that that fall will be life altering and will shorten your overall lifespan and reduce your quality of life. So these are things that are very important to wrap our arms around to improve our healthcare delivery so that people have improved patient outcomes. Because even if you have an adverse event that is survivable, often it contributes to later morbidity and mortality. Next slide, please.
So we have Kevin coming up next, but I thought we would go ahead and take care of those first polling questions.
Yes, this is a great place to have those. Thank you, Deb. So we will have a couple polling questions come up. If you could please just either answer on screen or we're asking you to type in chat if you don't neatly fall into these buckets. So first up, we're curious, does your organization have an opioid risk assessment integrated into your electronic health record? All right. So it looks like our answers are in there. It looks like about 25% of you say yes, you do have those, but 3/4 of the audience do not have that integrated into their system. We can go to the next polling question, please. So now we're curious about PDMP or prescription drug monitoring programs, and we're curious, does your organization have a system or a policy in place where you are required to check your state's PDMP? So depending on where you're located, this is often state mandated. I know for Wyoming, it is a requirement that it be regularly checked, but that regular is not necessarily defined. So. And it looks like about 60% of people do have a policy in place that's helping them check their PDMP, and about 40% do not. We can go to the next polling question, please. So now we're curious, are you seeing an increase in patients with substance use disorder or pain management concerns since the start of COVID-19? So it looks like we're pretty split there. No one is seeing a decrease, which I think is important. About 40% are seeing an increase and 60% have seen no change. So this continues to be an issue for people. We do know that pain management is a top concern for patients and many primary care providers. Next question, please. Oh, sorry, if we can take this one down. We're going to revisit this one at the end of our presentation and talk about the CDC guidelines. But with that, I'm going to pass the baton over to Kevin, and he's going to talk a little bit about Sync Health's experience around opioid risk reduction.
All right. Thank you, Stevie. First of all, I may apologize in advance. Allergy season has hit in Nebraska really hard, and I'm one of the lucky participants that gets to have a lot of antihistamines and decongestants right now. So we'll start on the next slide. This is somewhat dated information, but does show a good trend. This is from a Blue Cross Blue Shield study a few years ago, and it shows a decrease, significant decrease by about 25% in the number of prescriptions for opioids over a period of time, 2013 to 2017, which is really good news. Unfortunately, you've seen the graphs showing just that opposite. Even the earlier one that Stevie showed going up. And a lot of those are due to what? The illicit drugs, the fentanyls, the heroines that we're seeing now more and more, unfortunately. And even during COVID periods, there were two spikes, one in the summer of 2020, and then it dipped down a little bit, and then it jumped up again in 2021, and then it fortunately has started to come back down, but it's still high and continues, especially with the non-prescription opioids. Next slide, please. Now, the opioid crisis didn't start with just one event, and it's not going to be solved with just one thing. There's prevention, such as drug take-back programs, education, that something we're doing now. We talk to healthcare professionals all the time. Even students in as young as third grade could use education. You know, way back with Nancy Reagan and the Just Say No, that still continues today. Treatment and recovery is where a lot of money needs to be put in and is, such as what most states do have in place with naloxone availability. I carry naloxone with me. You can go into a pharmacy. There's a standing order that you can pick it up. A lot of states have programs through federal grants that allow you to have naloxone at no charge. And then the identification and monitoring, which is really about the PDMP. Next slide. You know, if we focus a little bit more on prevention, this has a great opportunity to really get the drugs out of the hands of friends and family members that rummage through kitchen or bathroom drawers. Next slide. Federal policy and regulation is a lot of the time that I've been spending on recently. I've been interviewed, been working directly with a lot of federal agencies, ONDCP, the CDC, which, you know, in 2016 put out their guidelines for chronic pain, and those are in the process of being updated in the next year or so. And they already talk about PDMPs and what to do. The National Governors Association has provided some information, and then a joint Health and Human Services, Department of Defense, and the VA had some good documentation on this. Next slide. Within the ONDCP, they actually talk about interoperability and how you can increase the use of the PDMP by integrating it into your systems. Next slide. In 2018, the Opioid Omnibus Bill, I hate that word, was passed, the SUPPORT Act, Support for Patients and Communities Act. And there are sections in there regarding a qualified PDMP. One of those sections, and this particular piece is specific for Medicaid patients and providers, where it talks about each covered Medicaid provider must check, according to what the state designates, the PDMP, the prescription history. And they encourage and facilitate the integration of the PDMP into electronic health records or pharmacy software systems or the HIE. Next slide. Here's an example, and some of you are familiar if you do have this integration within your state or within your healthcare facilities. Oftentimes it's a one-click button. This is an example within our health information exchange, where when you pull up the patient, you can see at the top, there's some risk assessments. It might show the morphine milligram equivalent, see if the patient is seeing multiple providers or pharmacies, or even if they're having issues where there's an overlapping opioid and benzodiazepine. So with a single click or a tab in the EHR, the prescription history can be displayed with all that information. And this sounds great, but really, does it do what they're intending it to reduce the burden of providers who are required to check the PDMP either by state or federal regulations. Next slide. And Nebraska did a study on this at one of our healthcare facilities, hospital in Nebraska. And we took a look at both pre-integration and post-integration results. And you can see that the number of queries has increased, more than doubled after the PDMP was integrated. This is really important to providers, where the time it took to access the PDMP from going to an external website, logging in, pulling up the patient manually, went from 55 seconds to about 30 seconds. And the number of clicks, and I'm not sure if there are any physicians on this call, but they'll say every click in the EHR is a heartbeat. And we've been able to improve that from 9 clicks down to 2 clicks. And some systems, it's even down to 1 click. So a lot of the screens that you've had to go through to pull up that information has decreased as well. So there are some tangible, objective benefits to doing this. And if you're forced to do it, if you're required through state or federal regulations, this just shows some of the benefits. You do get an ROI out of this. Next, and I can turn it back over to Stevie on this.
Thank you, Kevin. So we just wanted to give a little snapshot into sort of the why behind risk assessment. And if you are a Wyoming provider, you might be thinking, that's lovely. Our opioid data is hidden behind several layers, and we don't have this integration available to us yet. And I would just ask you to bear with us and continue to learn, because our PDMP provider is changing, and these tools and tricks and ability to integrate into your EHR will be available soon. And so we're hopeful that we can start having those conversations about what integration would look like at your location. More and more, this is the national standard. And as Kevin demonstrated in his last slide, it really does decrease burden for providers and allows us to do this at those points of patient interaction and engagement so that we can meaningfully and quickly assess patients' risk and really improve the delivery of care and increase the quality of those conversations that we're having with patients who have pain management concerns. So if you feel like this is not available in your location, hold on, because it probably will be very quickly, and we're happy to help have those conversations. Next slide, please. So when we talk about opioid risk assessment, that can be PDMP integration. A lot of times there's an algorithm that can be built in, or you can just simply add in some questions into your EHR through a standardized form that allows you to really start talking about patients' risk. This does not have to be a huge involved conversation. There are a lot of components that fall into opioid risk assessment. I like to talk about the 3 C's because I feel like this is very easy. Loss of control. We know that people develop physical dependency on opioids regardless of whether or not they're using them appropriately. So these are some possible expressions for people who can help cue you into this person is having an issue, and we need to have better conversations around their utilization of their opioid. We can talk about cravings, people who are preoccupied. This can be a result of inadequate pain control, or it can be an indication of ineffective treatment or a need for assessment for opioid use disorder. And then lastly, we have negative consequences. So one that's easily missed is oversedation and somnolence. The goal of pain management should be getting people back to their activities of daily living and finding the right balance for them to manage their pain, allow them to return to their normal activity while still improving their function. And so if we're starting to sedate them too much, we are likely overutilizing our opioids, and these are just good conversations to have with patients so that we can find out what their goals are and also reducing their risk. What other things do they have going on in the background that can increase the risk for these negative consequences? and start building the scaffolding that we need to reduce those risks so that the patient can achieve their goals with the most safe medication delivery as possible. Next slide, please. Provider involvement is key in any of this drug management. So there are lots of things you can use to build this off of. A lot of our payers have started to build in drug management programs, and these are some of the basic components. Those same scaffolds and requirements can be utilized in a clinical setting where you can tailor them to your individual patient population need. It's looking at key components like, are these medications appropriate? Are they medically necessary? Is it safe for this particular patient? Are they at risk for misusing or abusing their medications? That often falls into buckets of social determinants of health, starting to assess what they have going on in their family background or their personal background that increases their risk, such as being male, we know increases your risk of opioid use disorder. Certain age populations and certain health occupations increase the risk. And so having those conversations at the point of prescribing can really help impact and prevent those risks and development of opioid use disorder. And then looking at what drug management program tools might be available either through their primary payer, things that can support, or things that are available in your community, whether that is a pain management specialist or opioid use disorder treatment programs. Often we pull those things in too late, and we need to know when it's time to refer. And so looking at those resources that are available. Next slide, please. There are lots of safety alerts that have happened in the pharmacy world. As Kevin and I both mentioned, we're both pharmacists. And so I did want to talk about the different supply limits that are available. This is depending on what side of the aisle you sit on, a good or a bad use of electronic health records and hard stops. So we're looking at hard safety edits that are happening where we cannot move past them in the pharmacy world until these things have been resolved. This helps identify people who are opioid naive, who are maybe at more of a risk of developing opioid use disorder. We know those first 5 days are really critical, maybe as early as the first 2 days of an opioid treatment. These are opportunities for us to have good conversations and reduce patient risk right off the bat so that hopefully we're preventing the development of an opioid use disorder, but also can be utilized for patients at any point in their treatment program to have those conversations and get them access to the care that they need. Opioid use disorder doesn't have to be an end stop in our treatment program and should not be a reason for firing patients. It's just an indication that they need a different level of care. So I think these are a good example of places where technology has helped improve safety for patients. The pendulum swings both ways, and sometimes we know that increases barriers, but it is a model that we can help springboard off of, and we can put this upstream so that we can start having those conversations earlier rather than at the pharmacy. Next slide, please. So with that, this is our very quick introduction to opioid risk assessment, why we're hopeful you will all start working with us, and then begin the conversation about opioid risk screening tools. We're hopeful that we can encourage you to screen everyone in your practice. And I wanted to give a moment to just see what questions maybe have come up as we've been talking, and give opportunity to talk a little bit more. We do have one final polling question that will pop up on there, but feel free to chat into either the chat or the Q&A section, any questions or comments you have for us.
Thank you, Stevie. We have nothing in chat or Q&A at this point in time, but I certainly appreciate the effort and the time that you guys have put into this and spending your time with us today. And I'm excited to see what we will review in sessions 2, 3, and potentially 4.